Hello and welcome everybody. We are here for the virtual webinar for SASS, South African Estimates. And this evening we are going to be talking about intimacy. We have some fantastic guests from all around in the medical industry. So today we're going to start off with having an introduction from our guest speakers. We have some of them that unforeseen circumstances have obviously arisen, and Fazil is at the moment busy with Ramadan and will be joining us soon. So the introduction of our guests will be as follows. Our first guest speaker will be Sister Jolanda, who is a stoma therapist. And then we will have Vlooi Venter. She is with the CANSA Association of South Africa and the National Training and Clinical Nursing Specialist. And then we have Cheryl Thomas, who is a senior manager at Hollister and their global clinical educational specialist. We have got two other guests that are either having technical issues, like I mentioned, or have circumstances that are unforeseen. So we will either have them popping on later, or if they do not pop on, I will just introduce them before they appear on stage. I hope you enjoy this. Please ask questions. Please engage with us as supporting you as an ostomate with the information that you'll be receiving as an ostomate in the intimacy talking about intimacy today. So I'm just going to invite them all on stage. So we got here Nurse Jolanda, she's a stoma nurse. Then we have Cheryl Thomas, who is from Hollister. And then we have Vlooi, who is obviously our lovely associate from a CANSA association. So welcome, ladies. I think our very first guest speaker will be Jolanda, who is going to be joining us and sharing obviously a presentation on intimacy, and we're looking forward to engaging with her. Please ask questions if you have any as a stoma patient, or you are going through a struggle and would like some support. We are here to assist you. So just before we also start, I'm just going to share this. You will see a note at the bottom of the screen, which is allowing you to understand that we are giving you information, and we express this during the session for you to know that this is information and educational information for you as an ostomate. Thank you, everybody. And Sister Jolanda, you may take the stage. Oh, you are on mute. There we
I'm
go.
on mute.
No, it's fine. You're on.
Can you hear me?
Yes.
Okay, right. So I'm going to be talking about intimacy with an ostomy to all of you tonight. Now, this is normally a very difficult subject, but let's get started. The old saying is true. The way you see yourself influences the way others see you. And I think I want to read that again. The way you see yourself influences the way others see you. And that's very important to remember. So take time after ostomy surgery to acknowledge the changes your body has been through. Check in with your emotions about how you feel post-surgery and share your feelings with your partner. You will find that acceptance of your body after surgery will make all the difference. An important thing that I am starting off with that I really want you to remember, even if you don't remember anything else, is that we fall in love with another person's soul. Without it, the body is just an empty vessel. And there's that old saying that says beauty is only skin deep and it perishes. But the souls that love, they will remain forever. And that is something I need you to remember. So, in terms of intimacy, as a stoma nurse, I feel that it is very important, pivotal in the acceptance process of the stoma and also of your body image to have pre-operative counseling where you can ask all the questions in the world, but I really try and get the partner involved and have the partner present at these counseling sessions, because it is important to establish what the intimate life is like before, and to tell them that if there are any problems, that they should be addressing it before the surgery, because would not have gone away after the surgery. It will still be there. Then, depending on the type of surgery that you are counseling the patient for, as a stoma sister, we normally know whether there is going to be work done close to any of the nerves, or whether there would be potential intimacy issues, so that we can set realistic expectations post operatively and open the door to discuss it when they come and see us in our clinics again afterwards, because post-operatively they're so busy adjusting and coping and learning their new skills, and it's such a lot to deal with that sex is normally on the back burner. So I make a point of it that when I see them in the clinic after they've been at home for a while, that I actually bring up the topic and talk to the patients about it, so that I can open the door for these discussions, because it's not something they will come up with by themselves. And I often find that they go home and the husband and the wife will sleep in separate beds because they're scared that they will hurt each other. And if you don't talk about it, nothing will happen, and their relationships will just, you know, go south. So I want to tell you that in terms of intimacy, there's only one rule. Never use the stoma for intercourse under any circumstances. You and your partners should never use the stoma for penetration either, any kind of penetration. Transition back to your sexual activities is something that I think people, especially men, they think about it before the surgery. So resuming it after surgery can be an emotional and challenging time for both you and your partner. And in most cases, I have found that the ostomate will be coping with the effects of the surgery and the recovery. They're adapting to the new skills that they've learned to cope and take control back of their own bowel habits or urinating habits. And then there's the changes to self perception. Um, and it really makes them feel very insecure. Uh, it goes from being naked to being dressed, and not knowing how to hide or what to do with noise. Then, on the other hand, the partner may be worried about causing discomfort during intercourse, or even worry about the ostomate's reaction to the pouch and the stoma during intercourse. So, those are all issues that you as a couple need to talk about when you are starting to think about going back to sexual activities. It's important to discuss feelings and responses to the changes that have occurred to both of you, because although one person has had the surgery, the other one has seen the ostomate go through it and it affected that person as well. There will undoubtedly be fears about feeling sexy, about being able to stimulate each other visually, sexually, and about being able to respond. But the more you stress about these things, the less they will happen naturally. So, if you haven't seen your partner's pouch or stoma, it is probably because you were not available or present during the pre counseling and discharge counseling and teaching sessions. Um, so, I would advise that you consider exploring the pouch and the stoma together before engaging in any sexual activity. It's important for the partner to understand that the stoma doesn't have any nerve endings and will not be hurt, and encourage your partner to actually touch it and tell them that you can't feel it so they won't be hurting you if they do touch it during any activities. And then start off slowly. Think about having a shower or a bath together and using that time as a safe opportunity to start touching and caressing each other again. And then things will just progress from there naturally. It's also important to find room for humor because the stoma will make unexpected noises and sometimes it might feel or sound like there's three of you in the room. So be prepared for that. Try to avoid timelines and specific expectations about resuming sexual activity. Explore alternative ways to be intimate and do not expect penetration the first time so that you don't set yourself up for failure. And talk to your partner about taking it slow. In general, we normally advise that you wait about 3 weeks after surgery before initiating sexual activity. But again, it depends on the type of surgery that was done and how big the surgery actually was. So, if we look at some tips, I must say that I have found in all the years that some spontaneity may be lost, particularly in the beginning, as they learn to manage the pouch and stoma during sexual activities. But with a little planning, they can make it a special time and less worrisome for the both of them. Please empty the pouch before your time together and consider securing the pouch in some way to prevent it from moving or flapping during intercourse. Like use some tapes across the pouch onto the abdomen just to secure it, or maybe use a concealment device such as a cummerbund or crotchless underwear for the ladies. Weight on the stoma will not harm it, but friction can cause bleeding. So it's important that your partner understands that and does not go into a frenzied panic when there is a little bit of bleeding. So try different positions and discuss and explore together. Try smaller, more discreet pouches, such as a closed end pouch or a stoma cap. And there's also stoma caps available for the two-piece systems. Just speak to your stoma nurse about it, and they will give you and show you all the options. Don't keep quiet. If resuming sexual activity remains a challenge for you both, you may benefit from the expertise of a sexual counselor. Ask your surgeon or stoma nurse to provide you with options and a referral to a professional who can help to guide you and your partner back to a fulfilling sexual relationship. A sexual therapist that I have worked with previously have this saying that in any marriage or relationship, if there's a problem in the bedroom, it is 90% of the problem of in the relationship. If there's a problem in the relationship and there's no problem in the bedroom, they can overcome anything. So don't let this become the end of your marriage or your relationship. It is something that you can overcome together. So there are many options for both of you out there. Please don't keep quiet. Speak to your stoma nurse about it. So when it comes to single people, there's always this big question when to tell. Tonight I want to say to you, your stoma does not define who you are or what you can do. You are not the ostomy. You have an ostomy. It saved your life and your life has meaning. You add value. It's completely up to you when to tell a new romantic partner about your ostomy. So you may want to take some time to figure out what you want to say before you say it. And it's okay to keep it short and basic and then decide if you want to take some questions afterwards. I think it's important to remember that most people are just curious and most people are willing to learn. Now, in terms of different schools of thought, in my practice, I have come across people that would immediately, if they start in a relationship, tell their partners. And then they feel that if they are going to be rejected, then it's in the beginning stages and it's not going to break their hearts later on. But these are people that are so confident that they have the attitude of take me as I is or leave me, but I am definitely not changing for you. This is me, this is all of me, take it or leave it. Then you have the people that are a little bit more reserved and they feel that they will only tell when the relationship moves towards the part where you have to get naked. So with the clothes on, you are able to hide your ostomy and you don't have to tell anyone about it unless it's your choice. But if you then want to start, just to give you an example, it's important to discuss with your partner before you actually get naked. And you can say that you've had some disease, which you've had, because you've all got different stories. You had to go for major life saving surgery and it left you with a pouch. And then start answering questions. It's just an idea that I'm leaving with you about how to approach it. Um, so I want to say to you that you are very special to someone out there. Never change yourself or dim yourself for someone else's comfort. Of course, be willing to change and compromise slightly because it's a big part of relationships, but never lose sight of who you are. The right person will love and embrace you and help you to celebrate who you are. People who are meant for you won't mind about your ostomy, and people who mind your ostomy honestly don't matter and don't deserve to be in your life, in your heart, or in your headspace. So live life to the fullest because you can, and thank you.
Thank you, Jolanda. That was fantastic. Thank you for sharing that. So, as mentioned before, we had a few of our guest speakers that had some technical issues, and now we have them back. So, Dr. Dena, Dena is going to be joining us. I'm going to add her to the stage. Welcome, Dr. Dena. You are going to be our next guest speaker. So, Dr. Dena is a gynecologist and she is going to be talking about a few things as well around intimacy as an ostomate. She is an obstetrician, a gynecologist with medical law and ethics practitioner, human reproduction, technological from Valencia University, Spain. Has a special interest in endocrinology, if I've hopefully pronounced that correctly, and reproductive health, currently practicing at a Lenmed private hospital, Lenasia, and a keen interest in farming and creative arts. So welcome, Dr. Dena. I know that you have now disappeared from the stage again, but we will. Perhaps she's having technical issues, so I do apologize. But here we have Fazil Jacobs, who is the original presenter for this evening, and obviously from SASS. Welcome, Fazil.
Thank you, Candace, for picking things up for us this evening. Welcome to our guests. Jolanda, as usual, thank you so much for all that you've done for our community. I think we're going to try for a moment to wait a moment or two for Dr. Dena to try and connect. And I see she's back with us. Dr. Dena, can you hear us? I think she's having connectivity issues.
It looks like she's on mute.
Yeah, but it also looks like she's having connectivity issues. Candace, can we unmute her?
No, she's muted herself on her side. Unfortunately, she will have to unmute herself, please.
Dr. Dena, if you can unmute, please. Perhaps while we're waiting for to see if Dr. Dena can connect, Jolanda, if I could pose a couple of questions that got sent through from those watching. The first one that just came through, it's a bit of a deep question though. From a psychological view, post-surgery, could one have a higher sex drive because of the removal of sensation in the rear to compensate? Then he goes further to say that Freud has a theory that relief of using the toilet is related to pleasure.
Oh my word.
Very deep one, that.
I'm sorry, I'm not laughing at the question. I'm laughing at the fact that I've never heard of that before. And I don't know the answer. I'm going to be honest. I think this would have been a perfect thing for Dr. Ahmed to have answered. But in my knowledge, I am terribly sorry. I can research on that and ask around, but I don't want to just say something and then it's the wrong thing. I am so sorry.
Sure. I think, Shaib, if you don't mind, what we'll do is Sister Jolanda will ask around about it, and then we could post a follow-up on this video as a reply
what
to
I can say to you is that in males, if they do work that is close to the rectum, and if they do work that is at the lower part of the actual intestine, they do work close to the nerves. And in my experience, I have only heard about people not having that feeling, so then they have erectile dysfunction, or they don't have the correct feelings that they should because of nerve damage. But I've never heard about
a heightened drive.
A heightened drive or pleasure or anything like that as in this question. So I'm really sorry that I can't, but I will find out and I'll let you know, Faisal. Then you can get back to this person if you don't mind.
I'll do so. Thank you for that. See, Dr. Dena is back with us. Dr. Dena, can you hear us? Has she frozen again?
Hi, Faisal. She is on unmute. She can, if she can hear, she can verbally say so.
Dr. Dena? I think we're having connectivity issues there. So, Jolanda, before we hand over to Vlooi, I'd like to go through a few more of the questions. We've got 4 here. I'm new to this and struggling. Okay, I will respond to this person in private. So it's just related to diet. So it's not actually related to the talk of this evening, but I'll send through a message to this person with a link to some articles that we have up on diet. Another one is ED treatment. I've tried alprostadil did work for a while. I have a permanent colostomy because of cancer. I'm
Okay,
assuming that person could see.
that is a medication that is used for erectile dysfunction. And obviously, if that medication is not working for you, it is really necessary for you to go back to your doctor, preferably a urologist, because they will be the best person to help you with that. Because if medication for erectile dysfunction does not help, then they will be able to give you the alternative options, surgery, and everything else that can be done to correct it. So please don't just leave it there. Go and see a urologist, and they will help you with this problem.
Thank you. Thank you, Sister Yolanda. I'm just looking at the other two questions we have here. It's not really related to the topic of this evening. So if it's okay with you, Yolanda, I'll send you those questions if you wouldn't mind just formulating a response to them, and then I can pass it on to the necessary patients.
No problem.
Okay. So thank you to those who have sent through questions already. We're going to try and keep it topic specific, but those that's fallen out of the scope of this webinar, we will get the responses to you via email shortly. So thank you for that. So from there, what I'd like to do is hand over to Vlooi, who is with the Cancer Association of South Africa. Vlooi goes about the country training the staff, patients, nurses, all in the wonderful work that the Cancer Association does within the community. And I'm one of the patients at the Stoma clinic here in Cape Town, and I know they do wonderful work, and they've also got a lot of services that they offer to the ostomy community that I don't think many people are aware of. So I'd like to hand over to Vlooi and to tell us more about this. So welcome, Vlooi.
Thank you, Faisal. Thank you, everybody. Yeah, it's a privilege to be here and talk about our services. Thank you. We can go to the next slide. We've already had my introduction, and that's just recording notice. Thank you. So slip that one. Okay. Now, Jolanda spoke about this one, and it's so true. If we start talking about ostomies, it's lifesavers. So it's, and you are not defined by the ostomy. You are not ostomy. You just have an ostomy. Next slide, please. If we talk about intimacy, and as our previous speaker also mentioned, intimacy is not equated to sex. It's far more. And to be able to share, sharing is always caring. There's that saying, sharing is caring. And it's a whole range of sharing of thoughts and feelings, the experiences that you as a human being have, because it's not the fact that you have an ostomy doesn't change the fact that you have exactly every single feeling plus more after you have the ostomy. And it involves a lot of being open and talking through your own emotions, and very important here is letting your guard down. And Jolanda spoke about it. It leaves you vulnerable. Sometimes things like your body image that had changed, or just talking about it can have a serious influence. Now, and what's also very important here is these feelings is not necessarily only to a love relationship partner, but also sharing those intimate feelings. If we talk about intimate, it's not only sex, it's not only a lover's relationship, but it's also those feelings that you don't want to shout from the rooftop. That is actual intimate feelings that you feel, your dreams, your what about your future. Those are all things that's part of intimacy. It's you inside. It's not things that you. It's not the rooftop type of stories. Thanks. Next slide. Now, if we look at the services that CANSA offer specifically to the ostomy, if we first think about uh, products, now we all know products is essential for functioning of the ostomy, whether it's intimacy or whether it's actually your day-to-day functioning, you need the correct supplies. And we have two huge Stoma outlets, plus a door-to-door service. And the one is right down there in Cape Town. The other one is in Pretoria. And that's basically for anything that's not in the Cape Province. Up to just before Bloemfontein, everything north and towards KZN is actually serviced by the Cancer Stoma Pretoria. It's on the Cancer Care Centre in Pretoria and the same physical address as the Boana. And the address there is 32 Lake Street, Rietfontein. Then we have our wonderful outlet in Cape Town, which is 7 Dunbar Street, Athlone. It's also the care centre for the whole cancer care centre there, as well as the Akerhof care home where people can stay and live while they are actually on treatment. For instance, radiation, a lot of the patients can stay there for the duration of their treatment. But in any case, so at this Stoma Centre, we actually have Stoma supplies of most of our most common brands in South Africa. But also, there's also a service that I want to mention here. We have donated stock. In other words, a person who might have had a reversal of a colostomy or were in the unfortunate position of having a person passed with a colostomy or ileostomy or genostomy, doesn't matter which one. Please keep in mind that all these donated stock can be like a lifesaver and a rescue boat for someone who cannot afford a product. So we also do have donated stock. So keep in mind, if you know about people who have stock that they don't use or they've actually started using a different product, then all the old stock, hopefully not years and years and years expired, but they can bring it there. We can use it for people who really are in need. And that is at 7 Dunbar Athlone. Faisal, you are very afraid to our service there, as you mentioned. Athlone sounds a horrible area. It's not necessarily all that horrible, and they have now some more safe parking in the area. So just keep in mind, it is a bit better now. Now, then we have, so that's product. And then we have our telecounselling service, where, and this service is available in 7 of the official languages. It has to be booked, so they can book. You can call for a booking at 0800. It's on the screen, 226622. And then it is in languages available in us issues Zulu, Afrikaans, English, obviously, isiXhosa, isiSwati, Sesotho, and then Seswane. So that is the telecounseling service that we have available. And it is where the estimate can be put into contact with a counselor, not stoma counselor. This is for emotional support, and very important here, what Sister Yolanda also said, is that remember, it's not only the ostomate that needs counseling very often, and it is the most wonderful thing to have telecounseling, both people maybe on the same line, where they can actually discuss, and they can have a objective counselor, trained cancer counselor. They are all social workers, and they've gone for pretty intense counseling courses, so they are able to help you in terms of emotional support. And then our Stoma WhatsApp groups. It's still on the slide then. The Stoma WhatsApp groups, it can be, you can also request just to join by the same number, 0800226622. And these WhatsApp groups is not the ones good morning and good night and sleep tight, and they are intended for ostomates to reach one another, because there's one absolute essential thing in the life of an ostomate, and besides products which he needs to for a daily and an understanding spouse, is another ostomate who understands what they are going through. Because in my heart of heart, I absolutely believe those are the ones who can really give support to one another. And that is what the objective is of our WhatsApp, the Stoma WhatsApp support groups. Next slide, please. And then we go to our most wonderful stoma therapist assistants. That is our clinical services. And that can be scheduled. Cancer can schedule an appointment for the ostomate with a stoma therapist, or at least a trained stoma registered nurse. But currently it is a stoma therapist that give their services to us, and we are so grateful for it, because ostomates, they are the essence in ostomate's life. So, and they can assess the health of that ostomy. Check if there is possibly challenges in your stoma. We know if there's body changes, if there is aging, if there is time lapses, the stoma can change, your needs can change, and they are the ones who can discuss different alternatives and different options with you, and also see for you as an ostomate, is the products that you are currently using. We are never, ever product pushers, never ever product pushers in these clinics. This is the service to an ostomate by the stoma therapist. Doesn't matter from which a company they or stoma supplier they must be. They have at heart the best and the absolute best for the ostomate. But if for instance you start running and suddenly there's a lot of sweating and it's a new sport for you, or you start swimming, your needs from maybe 2 years or a year ago might be totally different now, and therefore they are the ones who can best check what is your specific stoma product. Does it suit your unique needs? And again, these stoma clinics is at the 2 sites as mentioned. In Pretoria, it is then now obviously at the Stoma Pretoria Centre, which is 32 Lay Street, Rietfontein. And there is stoma therapist on a Monday and a Thursday. Then in Cape Town, again at 7 Dunbar Athlone, the stoma therapist on a Thursday. All of this is by appointment. Okay, so all they have to do is phone. They can either do it online or phone the stoma, the two stoma outlets, and actually make an appointment to see the stoma therapist, because these are made by appointments. And then also a new one in Bedford View, which is new in Johannesburg and in the whole of the Johannesburg region. And that is actually at our head office in Bedford View. So it's 26 Concord Road West on Wednesdays. So we have stoma clinics, stoma therapists. Thank you for them. On a Monday and Tuesday in Pretoria, on a Wednesday Bedford View, and then on Thursday in Athlone. And thank you very much, all the stoma therapists, for the wonderful work that you are doing with the Cancer Association. We are absolutely dependent on you and your help with the ostomates. Kindly next slide. But then we have online ostomy guidelines. There's the Cancer Ostomy website, which is the Care and Support Stoma website. There's a load of resources on the website, whether it is a diet and nutrition. Faisal, you just got quite a few questions there from people, because it is when people have an ostomy, and I don't need to tell it to ostomies, they know that nutrition, diet, feeding, what can I eat, what works, what doesn't work, is one of the most important things. So on nutrition and things like travel tips, and can you swim and shouldn't you swim, and can you bath and can you shower, and I also wanted to say there, in terms of our WhatsApp support groups, the WhatsApp support group, as I say, is contact one ostomate with another. That is the whole aim and objective of the WhatsApp support. And those WhatsApp support groups, is there a question?
No, sorry. I just want to say we are running low on time, so
okay.
kind of need to wrap up.
1 minute. And then also the cancer fact sheets on stoma and stoma care, and also on the fact sheets as well on nutritional guidelines for colostomy, for ileostomies and urostomies. And thank you very much. That is me.
Thank you so much, Vlooi. And again, the cancer services, I'm a user of them. I think they are good. The resources that's available, we need to use it. It's not always easy. I mean, we live in a country where we have too little stoma nurses. From what we know, there are less than 100 qualified stoma nurses in this country, and you have over 250,000 ostomates in the country. So, when we say you got to get your stoma checked regularly, it's kind of difficult when there isn't that much available. So when we have services that is freely available, like at CANSA, if you by the means to the ostomy community out there, go out there and get it checked, because it plays a huge role in our independence. I also need to point out, Flo, as Shuaib said, Athlone is not that bad.
Well, I had because I had so many people say, what? Please, the last slide. We need to have the last slide.
Oh, yeah.
Kindly. Just tell us that she is not beautiful. And that's it. That's it of me.
Okay. Thank you so much, Vlooi. Dr. Dena is trying to connect again. She is traveling, so that's why she's on a cellular connection. And she was just chatting to the guys in the hotel to hopefully give her a better connection. Dr. Dena, are you there? Dr. Dena? Okay, it looks like we're not going to win with Dr. Dena this evening. So sorry about that. What we're going to do is now hand over to Cheryl Thomas, who is with Hollister. And she's going to be speaking to us about a recipe. She's going to share a recipe to promote healthy peristomal skin. Cheryl, just give me one moment. I'm going to be sharing the screen. Let's just see. Can everybody see the screen?
Yeah.
Okay, awesome. When you're ready for the next slide, please just let me know and I will move it on. But over to you, Cheryl.
Thank you very much. And I am delighted to join you this evening. You'll guess from my accent, I'm sitting in the UK. So protecting peristomal skin begins with a skin barrier that provides a secure, a comfortable fit, and a skin-friendly formulation. And at Hollister, we focus on security and skin health when designing our ostomy skin barriers. So this evening, I'd like to take this opportunity to walk you through our recipe to promote healthy peristomal skin. Next slide. So living with a stoma does not mean that you have to live with irritated skin. And you've probably heard your stoma care nurses many times telling you that the skin around your stoma should be as healthy as the skin on the other side of your abdomen. Next slide, please. And the reason why we tell you that is that we are well aware that after stoma surgery, your healthy skin around the stoma faces new challenges. You are wearing a skin barrier 24 hours a day, which interferes with the normal airflow of the skin surface. You're repeatedly removing the skin barrier, which is known to cause trauma to the outer layer of skin. And if stoma output comes into your contact with your peristomal skin, it can be highly irritating. Next slide. So now let's look at the role of the ostomy skin barrier plays in helping to maintain that healthy peristomal skin. So to preserve healthy skin, there are two functions of a skin barrier that must come together, and that's fit plus formulation. And the right fit for a good seal around the stoma helps to prevent leakage, but it also gives you, the patient, comfort. And there are many different barrier fits, such as flat barriers, soft convex barriers, firm convex. There's barriers that you cut to the size that you wish them to be. There are barriers which are pre-cut to a certain size. There's barriers that have tape at the edges, and there's also barriers that don't have a tape option as well. But selecting the right formulation or the recipe or the ingredients inside the skin barrier that touch the skin, so we're talking about the formulation, is equally as important as the fit. Next slide, please. So you can see that the ingredients of the skin barrier have 3 main functions. And these are adhesion. So when we talk about the adhesion of the skin barrier, we're talking about the sticking power of the pouching system to keep you secure on your abdomen. And sometimes we refer to adhesion as being the tack of the skin barrier. We also require skin barriers to have the ability to absorb fluid-like moisture from around the stoma, or even from the perspiration on the skin underneath that skin barrier. But with the absorption of any moisture under the skin barrier, it's also really important that we have a level of erosion resistance. And what we mean by that, it's the ability of the skin barrier to hold together in the presence of fluid to give you the right wear time. Next slide, please. So I don't think the slides work because it was on a build, and I don't know whether, Fazal, you've taken it off, but I did have a beautiful picture of a cake, and this cake looked deliciously tasty and looked beautifully iced. But my question for you to consider would be that if I were to give you this beautiful cake, would you still consider eating the cake if I was to tell you that the sugar and the salt had been switched around? Next slide, please. Because the reason I would ask you this question is that it's important that while manufacturers still have the same type of product and they may use similar ingredients, their proprietary formulas create a different experience. So you can see on the screen there, we've got 2 very well-known soda brands. And if we were to look at the ingredient list, you would see that they've got similar ingredients. But when we taste these sodas, you will be aware that the taste is exactly not the same. So changing the mix of the ingredients inside products impacts the outcome. So another example, you can see my baking, which is not my baking, it's just pictures of baking on the screen to the right. And you can see that the bread on the right side of the screen, there's some rolls that have had the addition of extra butter, and there's some rolls that have been given extra eggs. So it's otherwise the same recipe as the control, but you can see structurally they are a little bit different than the control roll. So this is just kind of giving you an example of same ingredients, hashtag same experience. Okay, next slide, please. So when we take a deep dive into what the common ingredients are in ostomy skin barriers, these are what are present. So we have PIB, and then we have a mix of hydrocolloids such as gelatin, pectin, carboxymethylcellulose, or otherwise called CMC. And the next few slides, we're going to discuss each of these ingredients and showcase how they affect the skin barrier performance. Next slide, please. So we'll start with PIB. And PIB is short for polyisobutylene. And as we said, that this particular ingredient is responsible for ensuring that the ostomy skin barrier stays securely to your abdomen. PIB is an ingredient commonly found in chewing gum. And if you were to touch the raw ingredient of PIB, it's a very thick, viscous liquid, and it has an adhesive property, which we call dry tack. So if you think of it a little bit like chewing gum, so dry tack, but very little wet tack. So this means that the chewing gum might get stuck to the bottom of your shoe, but it doesn't get stuck to the inside of your mouth. So the PIB is very clever that it doesn't get stuck, it doesn't stick to the stoma, but it stays nice and secure to your abdomen. Next slide, please. So then gelatin is a hydrocolloid that's present in the ostomy skin barrier at Hollister, and again can be found in molded gelatin desserts or jelly beans. And the role of gelatin is that it absorbs fluid quickly. And did you know that gelatin is made almost entirely of protein? Next slide, please. So together, they're the same family of hydrocolloids, and we also have pectin. And pectin is another natural ingredient that is found in citrus fruits. And we often use this particular ingredient in making jams and jellies. And pectin is responsible for absorption within a skin barrier, but it's a slower absorber than that of gelatin. And pectin is the ingredient that's responsible for giving the skin barrier that beige tone. So this is sometimes, because pectin is a natural ingredient, you will sometimes see that there is natural color variation in a box of 10 or 30 skin barriers. So you may see that they're different shades sometimes of beige. Next slide, please. So CMC fits within that hydrocolloid category, and this is the thickening agent that's commonly found in ice cream. And it absorbs fluid at a rate in between gelatin and pectin. So we've got something that absorbs faster. So we've got three kind of different levels of absorption within the skin barrier. And CMC is also used in other food products like biscuits or candies to help more evenly distribute the fats to improve taste. So this is an ingredient as well, like the others that are found in other food substances. Next slide, please. So now that we've covered the basics of a skin barrier, so let's talk about new ingredients. And as we know in food, adding an additional ingredient or ingredients can change the performance characteristics of how you experience that item. So for example, if I were to add strawberries or chocolate to vanilla ice cream, this would completely change the flavor experience. Next slide, please. So Hollister is the first company in the US to introduce a skin barrier that's infused with ceramide. And the ceramide is added there, and it's to help design. It's been designed in that way to help keep peristomal skin healthy right from the start. So this infused barrier has got all the ingredients that we've just talked about, the same characteristics, the adhesion, the absorption, and the erosion resistance, but it also has the added benefit of ceramide. So I've now got a short video which will explain the benefits and what ceramide is to help maintain healthy skin right from the start. So next slide, please, Faisal, and play the video.
The importance of ceramide in a peristomal skin barrier. The skin is our body's first line of defense against infection and injury. Yet its ability to protect us is only as good as its ability to protect itself. The outermost covering of the epidermal layer, or stratum corneum, is what we see
Oh, sorry.
when we look at our skin. What we can't see, however, are the abundant amounts of ceramide. This waxy lipid molecule works by linking skin cells together to form a waterproof protective barrier, much like the roll of mortar in a brick wall. The resulting bond helps protect the skin by preventing water loss. Healthy skin has abundant levels of ceramide, which for people with stomas is important for keeping the skin around their stomas healthy. The CeraPlus skin barrier can help protect their peristomal skin from day one. The CeraPlus skin barrier is infused with ceramide, just like the outermost layer of the skin. This helps protect the skin's natural moisture barrier, minimizing the potential occurrence of peristomal skin complications and maintaining healthy skin around the stoma. Keep healthy skin healthy from the start with the ceramide-infused Cera Plus skin barrier.
So next slide, please. So the Cera Plus skin barrier provides skin health and security, and it provides skin health because you're using a barrier that's infused with ceramide, which is a natural ingredient of healthy skin. But it also provides security because the Cera Plus portfolio has lots of products that you need to ensure that you get a good seal around the stoma to prevent leakage and promote comfort. Next slide. And I think that we've heard this message earlier today in the presentations, in that one size or one product does not fit all when it comes to choosing the right skin barrier. And at Hollister, we have a wide range of configurations to achieve the best possible fit for all your body types to make you feel good to get on with your life. So we've got 1-piece and 2-piece pouching systems. We've got flat ostomy skin barriers, firm convex, soft convex. We've got pre-sized. We've got cut to fit. But we also have accessories which have ceramide included, and we have the Cera Ring barrier ring, and we also have Cera Plus, which is a barrier extender. So Hollister uses that unique combination of security and skin health in its design of its skin barriers, and this helps maintain healthy skin from day one. Next slide for a video. Next slide. So thank you for the kind invitation to speak with you all tonight, and I hope to see you again at some point. Thank you, Fazil.
Thank you so much, Cheryl. I think just one comment that came through here. I like your products, especially the comfort it brings, but I think I'm in love with the English accent more.
Oh, dear, brilliant. Thank you.
Thank you so much. Sorry, I just got Dr. Dena trying to give me a call here. If you guys can just give me one moment.
I'm entering on another device.
Oh, welcome, Dr. Dena.
Right? Okay, good. Sure, thank you. Thank you. All right.
The floor is all yours.
Thank you. Thank you. Thank you, Sister Jolanda. Thank you for the invite. Sorry for the delay in the connection. I just had to take an urgent flight to Nairobi, so I'm just trying to get the facility to help me to connect. But one of the gentlemen has been kind enough to lend me his device. All right. How many minutes do I have, Faisal?
You've got about 10 minutes. We can push it to 15.
Okay, great. Thank you. Once again, thank you for this opportunity. I just wanted to appreciate all the people that have spoken well. But just to give you an idea of the approach to stoma care in pregnancy, from pre-pregnancy all the way up until delivery and 6 weeks postpartum. First of all, it is a multidisciplinary approach, which means it will not just be an obstetrician looking after the patient. The most important people in this team would be the patient and the partner to the patient that is going to walk the journey with them. The partner doesn't necessarily have to be the father of the child, but has to be somebody who will consistently be there. Secondly, one of the important things pre-pregnancy in stoma care patients, because we are going to consider them to be moderate to high-risk patients, is definitely going to be the planning of the pregnancy. And in this instance, preferably if the patient is known to the obstetrician prior, that would be great. But even if they're not known, the planning of the pregnancy at least 2 to 3 months prior to the pregnancy is advisable. Because then we walk through the plan from the beginning to the end. We introduce the people that are going to be coming onto the table in this pregnancy, meaning the obstetrician will be there, the midwife will be there, the stoma care specialist will be there, the psychologist will be there, the nutritionist, dietitian will be there, the surgeon, general surgeon will be there. The physician support is also important. Should it be needed, will also be there. Importantly, I think, and I believe we'll be going towards that kind of a setup for all obstetricians, I'm hoping so, would be that the communication between all these people, all these stakeholders, including the patient and the partner, will not be one in which somebody just comes to the clinic on the day of the appointment or the antenatal clinic on the day of the appointment and comes back only when the next appointment is due. In my practice, for instance, every pregnant patient at the first visit gets onto my WhatsApp group. And my WhatsApp group entails all of these people. Sister Jolanda is one of them. So that if there is a challenge, seeing that this could be a medium to high risk patient, if there is a challenge at any stage, pre-pregnancy, pregnancy, post-pregnancy, delivery, there will be a communication that doesn't necessarily have to wait for the patient to come into the hospital. Somebody should be able to send a message to any one of these people on the panel in the group to say, Sister Jolanda, I'm a stoma care patient. She will be aware of the patient in any case because she will have joined the group and Sister Jolanda will be on the group. But I have X and Y challenge. So we're not having a situation where we're waiting until there's issues before then the issues have not been addressed in time, and then we're running around now at the last minute trying to get help. So I would advise any and everyone, patients, prospective patients, and even people that are passionate about stoma care. If you do have a patient that you know is planning a pregnancy or is pregnant, direct them to obstetricians within their vicinity who are going to have this multidisciplinary kind of an approach, and are going to be accessible, and they will be able to respond should there be any challenge at any given time. That's very important. I'm also wanting to say that stoma is not a contraindication to fertility, to subfertility, and to infertility. It's also not a contraindication to pregnancy. So the myth is out there that a woman with a stoma cannot get pregnant because of ABC, and that is not true. You can get pregnant, you will not be subfertile, you will not be infertile because you have a stoma. Okay. And also having abdominal surgery that has no complications as well should not impact the reproductive organs. And that is something that all stoma patients need to be aware of. So let's get into the early pregnancy stage. Once the stage is set, the pregnancy continues as per basic with everything that the woman needs to do during the pregnancy. All the vitamins need to be taken, the bookings need to be done, the bloods need to be done, and all of that. All the stages of early ultrasound, first trimester, second trimester, fetal anomaly scan, everything goes according to plan. The visits that we're going to set up for each and every stoma patient had to be individualized, because some are high risk, some are medium risk. So you need to make sure as a clinician and even as a patient, be aware that your visit is likely not going to be the normal 4 to 5 week visit. It could be closer, 2 to 3 weeks. It could even be closer than that, depending on what it is that we are dealing with. So each and every patient, each and every lady has to be individualized in terms of her care. Nausea and vomiting is a very common challenge early in the pregnancy, first trimester going to second trimester. The challenge with that is going to be hydration, dehydration specifically. Education needs to be important in the sense that if you start with any kind of nausea and vomiting that is not normal meaning that you're vomiting at least 3 times, or at the most, let's say at the least 3 times a day, you need to get onto your WhatsApp, speak to your obstetrician, let them know. Because once dehydration sets in stoma care patients, becomes kind of a challenge to reverse. And those patients sometimes just think, no, it's just a little vomiting, just a little this and that. And by the time they come into the hospital, they're really dehydrated. And I'm going back again to say the communication is important. Also, a pre-pregnancy into first trimester, your orientation as a patient is important. Meaning that after you've seen your obstetrician and you've seen your midwife, you need to sit down and have an orientation, in the sense that the patient needs to know this is what is expected of them from the antenatal care center, and also this is what they expect from us as caregivers. So it's got to be a two-way street. They need to know that it's not about we telling them what to do. It's also about them walking the journey with us. And your best patient will be the one that understands and is cooperative. Unfortunately or fortunately, there's what's called the pregnancy brain, so people forget all the things that have been said to them. And you might find that in this particular instance, it is more information that is more than information you would be giving to somebody who doesn't have a stoma. And so you need to be willing to repeat every time you see the patient, repeat what you said. In my practice, I send the WhatsApps every Monday to remind you, okay, this is what we said about this, is what we said about that, is what we said about this. Don't forget this, don't forget that, don't forget that. So that people are aware and people get reminded. And don't get irritated if they come back to you and say, but what did you say that day? And you're like, I don't refer them back to the WhatsApp. You'd have to talk to them again, because that's just the way it is with the hormones and all of that. Constipation can be a challenge in pregnancy, as we know, particularly as a side effect to iron being one of the supplementations that is provided to pregnant women. The side effect is constipation. We don't want to deal with stoma issues with constipation. I don't know if I'm allowed to say in this forum, there are formulations of iron that do not necessarily have to be tablets or capsules that you take. We know there's the iron infusions, but that's like something that we have to do if we have now challenges with picking up of iron. But there are formulations of iron. If you allow me, please type there, Sister Jolanda, so I can say not say the names. But those are ones that are actually don't have to be absorbed in the gut. They get absorbed through the mouth, through the lining of the mouth, so that they bypass the stomach and we avoid constipation challenges as much as possible. Let's speak about ultrasounds during the pregnancy. As pregnancy progresses, ultrasounds can become a challenge, especially if the head of that fetus is right beneath the point of the stoma, where the stoma is. And so your ultrasound specialist or obstetrician needs to take that into cognizance. And we often find that I have to now then do a vaginal ultrasound for such a patient, because the abdominal one for that particular view of the baby's head and of the pelvis is not very adequate. So be careful when you actually come in to do an ultrasound as a stoma patient, to inform, to bring more extra bags and pouches, because the gel that we use on our ultrasounds can sometimes form adhesions on the pouch. And so at the end of every ultrasound, then the patient may have to remove what they came with and apply a new one, just to avoid leaking and challenges like that. Imaging can become difficult as a baby grows, but then we're there to walk around that. We do say to all our patients, stoma patients included, that all your ultrasounds, your first trimester, second trimester, fetal anomaly scan, and others that you may need to do if need be, that are know that these are some of the challenges, and we walk them through that. Okay. As the tummy grows, the stoma size can change, and which is normal, which is expected, and they should be aware of that. So it might mean that they may need to have larger pouches that will fit onto the stoma. You might also find that sometimes some part of bowel also gets into the stoma. They need to be aware of that, and they need to be able to care to know how to take care of that. The more difficult part of the pregnancy is usually in the third trimester, where Braxton Hicks become, they almost feel like labor pain. And you'll find that lady running into the maternity unit, I'm in labor, when she really is not. So that is part of the discussion, to say, if you got that kind of pain, I normally say to them, come in any case. Don't sit at home, just come. Come, let's get assessed. Let's get the midwives in maternity to assess you. Call me out if I need to call out your obstetrician if she or he needs to come out. But don't just say, okay, it's just Braxton Hicks, although they will be uncomfortable. In most cases, people do think that they are in labor. Nutrition, foods to avoid, is all the stuff that we normally say to our pregnant ladies, nothing special. We avoid mercury-leaded fish, which includes your tuna and your swordfish. Avoid your soft cheese. Avoid raw meat or undercooked meat. Avoid whatever obviously you're allergic to. Alcohol and tobacco is definitely a no-no. And raw meat and raw seafood, we also ask them to avoid that. However, nutrition is basically the same, in the sense that, hydration, fruits and vegetables, because we need to get that bowel to keep on functioning. I normally also ask them to try and increase the protein also in their diet. And that's where the nutritionist or the dietitian also comes in the group to assist where the people are struggling. I would say speak to your doctor and ensure that you are the communication is key to any successful pregnancy, whether there's a stoma or not. The clinical psychologist comes in the instances like this, where there may be challenges here and there. In fact, the partner that walks through the pregnancy with the client, with the patient, also has their own questions and their concerns and all of that, because that person is almost usually on high alert most of the time. So it is a 9-month period of pregnancy, and those stresses are going to come in, especially towards the end of the pregnancy, when we can see now it's time for delivery, or the Braxton Hicks are telling us that we're almost there. These two people can really get exhausted. So that is where the care from all members of the group needs to be heightened and more sensitized. Delivery is important. I normally advocate for normal vaginal delivery or vaginal assisted delivery, for the simple reason that we want to avoid as much as possible formations of adhesions, which is common, especially bowel adhesions after surgery, after any surgery. And this is a woman who's already had surgery. However, for those who have to have cesarean sections, we do our best to do the cesarean section in such a way that we're not coming back with bowel adhesions, which is a possibility. I may add that bowel adhesions are not a common factor for stoma patients. But just a little bit of extra care after a Caesar has been done before the abdomen is closed in cases like this. I try and wash out with saline thoroughly, because there might just be a little bit of blood here and there that is and amniotic fluid that's still in the abdominal and pelvic cavity. Try and wash out, which is after you close the uterus, try and wash out like you would wash out any abdomen after any general surgery. And you find that you limit the formation of adhesions. Some people use sterile water, some dilute the saline half and half into sterile water, but just do a thorough wash. That will be of use going forward. Care after delivery for a woman that has had a Caesar, minimum 3 nights stay in that hospital. The woman doesn't leave until she has done 3 full nights, because you want to have the patient there and you see, how are you doing? How are you coping? You need to be able to educate further when they get home. You need to be able to educate with the breastfeeding and make sure that they're comfortable with that for those who opt for breastfeeding, and so on. So I do not advocate for a woman to leave maternity unit if under 3 days of cesarean section and a full 2 days of after vaginal delivery. Healing is normal of wounds, whether it is episiotomy wounds or wounds from cesarean section. Healing should be normal. Here is where the high intake of protein comes in, because we know with stomas we do tend to have a bit of insidious losses of protein, and micronutrients. So this is where the high protein intake comes in and assists a lot with the healing. In my practice, I see my patients a week after they've had any delivery, 7 to 10 days after delivery. And the normal ones you would see 6 weeks post-delivery to do whatever you need to do, health education, pap smears, contraception, and so on. But for these particular patients, I normally advise see them at least on a 3-weekly basis, meaning after you've seen them the first 7 to 10 days post-delivery, see them again maybe another 10 days after that, just to establish that they're doing good. And keep that communication open as well for them to be able to send you a message and say, or whoever send you or whoever is in the group amongst the caregivers, whether it's a psychologist or whether it's the stoma care sister or the midwife or myself or the obstetrician, to say that this and this is going on, is that okay? This and this is going on, is that okay? And so on. One of the things that you might find that might work a little bit more slowly is after cesarean section is going back to a normal bowel movement after Caesar. That's one of the things that you want to ensure after you have done a Caesar, that the bowel movement is normal. And normal doesn't mean just little pellets, like you've gone back to a normal bowel movement. That's very, very important. I also want to say that hopefully caregivers are going to go back into are going to attempt to hook their patients up, especially patients that are needing continuous care, because pregnancy just doesn't end because the patient has left your room. Pregnancy continues, and as long as it continues, you need to be able to be accessible and available. That we should be able to have in our groups access to, we need to be accessible. A successful pregnancy entails that kind of accessibility, a kind of communication that is the back and forth communication. The other challenge as well with patients on medical aid that one needs to orientate them about during the orientation period early in the pregnancy is that your medical aid might not cover for all your visits. Here you are that are needing maybe more than than the normal 3 or 5 visits that your medical aid covers with your obstetrician or your midwife. And try earlier on to, I normally write letters to the medical aides and motivate to say, this is the situation that we have with this patient. She will need not just the 5 visits that you guys are paying for because of X, Y, and Z. And I do find that they do comply. But that needs to happen earlier on in the pregnancy so that we're not running around with the patient now getting really frustrated. She has a visit that she needs to come and see you for. Here's a challenge that has come up, and now what does she do because the funds are not allowing her to see the healthcare provider as she should. And that's where the issues come in terms of complications, because now someone is sitting at home and has not communicated because they're worried. They're thinking, okay, there's all this money I now have to pay. Is the pregnancy this side? Is the stoma this side? So these are people that one needs to be careful in the sense that you orientate them well and you ensure that the medical aid has approved for further care. I don't know if I've missed anything or if there are any questions. If you could please just let me know.
Sure.
I'm sorry
Thank you
for the mishap.
No worries. Thank you so much. I think it was very, very informative. I did get a couple of questions come through to me directly. The one was, is the risk for developing a hernia in a pregnancy higher?
I have seen prolapses of bowel into the stoma. I haven't actually seen hernias per se, unless they had a hernia before that they weren't aware of. Usually it would be periumbilical, but hernias per se are very rare. Although if they do present themselves, then I would normally refer. I'd normally refer to the general surgeon to see what we can do in terms of hernias. Usually they don't do anything about them in the pregnancy if they are manageable hernias. Periumbilical hernias would disappear after the pregnancy. But even if they do occur, they are not usually huge, and they will not occur in the areas where the stoma per se is, because in that case, the bowel will just do a little bit of a prolapse, and that's basically it. And the stoma sister can teach them and show them how to manage that.
Okay, thank you for that. I think the next one will probably be more for Sister Jolanda, and that is, the chances are my pouching system will change then during pregnancy, and it may change more than once.
Sorry, Faisal,
Can you
just
say
say
that
that
again?
again.
So the question is, my pouching system will most likely change during the pregnancy, and it may change 2 or 3 times.
That is correct.
Correct.
Okay. Thank you so much. I hope that answered all those questions of the viewers. I don't want to keep us up for too much longer. I want to thank you all, and we're 30 minutes over the allotted time, but technical mishaps happen, and we appreciate the perseverance of Dr. Dena. And thank you to all of our guests and our viewers. The information that came through was extremely valuable. Some of the feedback we're receiving is really, really good. So thank you so much for being a part of it. Thank you for your time, and enjoy the rest of your evening.
Thank you. Bye-bye.
Goodbye.
Thank you. Bye.